surgeon at Orthopaedic Children's Hospital in Liverpool. And my main specialty interest is in limb reconstruction. So typically, I'm referred to patients like this, a 12-year-old girl who at age 6 had a proximal tibial fracture, which developed a valgus deformity and was anticipated or hoped that it would resolve, but unfortunately it didn't. And so my Pavlovian response to this is to put the framework, get it straight, and sort it out. Similarly, I sometimes see children who've got calcaneus deformity for over-corrected club feet, and again, he's 15 years old, Pavlovian response, put the framework, do a plantar flexion osteotomy, do tendon transfers, shorten tendons, lengthen tendons, and you get good results. However, in 2005, Peter Stevens visited our department and he reintroduced the concept of guided growth using his 8-plate as a tension band. He reminded us that we can use it in any physis, even sick physis. Typically, it was indicated for around the knee, but it can be used around the ankle, the hips, the elbows. And traditionally, he said, the best correction would be in coronal plane, but you can also use it for sagittal plane deformity, for limb length discrepancy, and also, importantly, for minor to limit deformity progression. So the typical cases we started using this was, geobarum, and you get nice correction, tibia valga, nice correction again. But before wholeheartedly embracing this technique, we felt that it should have certain attributes. It should be simple to use, it should be cost effective, and it should be better or as good and safe as what currently exists. And most importantly, it should be able to deliver good results in all hands. So Peter Stevens has described this as having a learning curve of 1. And in our hands, we found that once you've done one, it doesn't hold any particular demons. In terms of cost, it's comparable to what exists. And in terms of being better or as good as what exists, yesterday we've seen basic sciences which suggest it does what it's meant to do. It's exercise-here, it's flexible, so there are attributes that suggest that it's good or better than what existed. But importantly, when we look at our own figures, we saw that we can reliably achieve correction in the coronal plane of 1.2 degrees per annum when measured in X-rays, and also in the sagittal plane, if you measure using a goniometer, you could achieve at least 2 degrees per month. So we knew that we can get similar type of results that Peter Stevens was having in his patients. So having gained that confidence, we started to think about, where else can we use it? And some of these cases I'll show you. So we've already shown that in hereditary multiple exostosis, it can be used to correct varus and valgus deformity of the knee. But what about that ankle? So this is a 7-year-old girl who came with valgus of the right ankle. She's got a larger osteochondroma, as you can see in the distal fibula. Fibula is a bit short as well. She's too young, she's starting to have symptoms. So what we've opted to do is to put a distal medial 8-plate. And over a period of about 15 months, it gradually corrects and it helps to maintain a vertical alignment. It's not perfect, but it's prevented the deformity from progressing. And even though this child may require something in the future, it's probably going to limit what we have to do. We've also used it in cases of fibular hemimelia where there's a ball and socket joint, because we know these kids are almost destined to get a valgus hindfoot. And by putting on a medial 8-plate again, you can see we can maintain the normal mechanical axis and prevent further deterioration of this anticipated deformity. This is an 8-year-old boy who again had this club foot treatment. He came complaining of pain in the ankle and he had a valgus hindfoot. Now if you look at this, unfortunately he's got a deformed talus, and that's probably where his pain is coming from. We've put him through the gait lab, we've done pedobarographic measurements, and it was sort of suggested to us that we should do a translation calcaneal osteotomy. However, we said you can do it, we may improve the shape of your foot, but we probably can't guarantee you're going to have improvement in your painful symptoms because of the changes at the ankle joint. Parents weren't particularly keen on undergoing surgery with very limited chance of success. So we suggested, why don't we try and correct your deformity using an 8-plate and see if that brings about any improvement in the shape and those symptoms. So again with him, we've done a medial 8-plate. Again, over a period of approximately 15 months, it's helped to maintain the ankle shape. You can see one of the complications, if you leave it too long and in the distal physis, it can be dragged through the physis. But for this particular kid, he felt that the shape of his foot had improved, and also he felt that symptoms had improved. So it's one of the reasons why using the 8-plate has proven to be such a useful tool, because you're working on other easy answers for this young man. This is an 8-year-old child, again, lots of complete overcorrected, and his range of movement was offsetting to dorsiflexion. So insofar as he couldn't achieve a plantigrade foot. Alright, so difficulty putting his foot into shoes or boots because he can't get a plantigrade foot. So in this case, we've opted to put a posterior 8-plate using the plane between the peroneus and the flexor lucis longus. And over a period of approximately 9 months, you can see we've helped to change the arc of his distal tibia. So we haven't improved his range of movement, but what we've done is given him movement in a functional range. My colleagues who do CP, I no longer do any CP, and Ravi told me that using the 8-plates anteriorly is effective and useful in certain cases. I think they choose their cases very carefully, but you can see you get nice divergence of the screws, and you can easily use it in cases of cerebral palsy with flexion deformity as opposed to an extension of certain. We've seen cases of blunt disease, so this was a girl who presented just after age 2. It was initially felt that she had idiopathic genoviral, but given that she was age 2 and it was increasing, she was referred to these x-rays. And so her management strategy included putting in a couple of lateral 8-plates, similar to the dietitian, to try and reduce the point of open number. And after about 9 months, we said, oh, she's getting better. That's aligning, but what's happening here? And in our institution, this is the X-ray that they sent us. So when we send the background, the X-ray, we can see what's happened here. There's a slight deflection of the 8-plate here, and she's actually broken that screw there during the correction. But that's not a catastrophe, because you simply change that screw, and this is a work in progress still. I see a number of patients with skeletal dysplasia as well. This is a 6-year-old girl who was treated for clubfoot and then was referred to me at age 6 with progressive deformity, particularly on the right side, but in both feet. And when you looked at her, she had facial dysmorphism and features suggestive of a skeletal dysplasia. We sent her to the geneticists, but they weren't able to give us a diagnosis. But she had the deformity, and the question is, what should we do? So we followed the typical pattern of trying to correct the deformity where it needs to be corrected. Medial distal femoral 8-plate. And at the level of the ankles, you can see here, the physes are oblique. So I have simply put 8 plates on. And again, this is a work in progress, and the anticipation is that she will show some level of improvement and probably limit what we may have to do to her in the future. As part of the roadmap in limb reconstruction, I've seen this 15-year-old lad who has had a synovial sarcoma here and was successfully treated with surgery and radiotherapy. However, consequential to that, he came with a 6-centimeter ligament discrepancy and a varus deformity of the tibia. When you look at the knee joint a bit more, you can sort of surmise that the radiotherapy has completely affected his distal femur. However, in the proximal tibia, I suspect it has had an asymmetric effect insofar as the lateral aspect was still functioning. So part of his treatment strategy was to put an 8-plate here to prevent further progression of any deformity from any residual growth here. Apply an external fixator to perform lengthening. If you notice, these pins are put slightly obliquely because Once we've achieved the required length, we acutely deform them, deform the regenerate, sorry. And we've got good alignment. Lastly, we've seen the cases of ligament discrepancies. So someone was asking about hypertrophy. This young lady does have it. She's seen our vascular surgeons who only treated her with graduated stockings. She was age 12 here and would have rejected ligament discrepancy of approximately 4 centimeters. Simply apply clips, and within a 24-month period, she's almost fully corrected. So in summary, it is safe, simple, reliable, and reproducible. It can be used in unusual conditions and may avoid or limit the need for major surgery. And lastly, I'm probably seeing less of this and more of this. Thank you.